I started training for cross country in June, and by September, my knee started hurting. By October, oh, I forgot. She diagnosed me with runner's knee, gave me a brace, and told me to start physical therapy. I went to physical therapy for 2 months, and they gave me different home exercises.
Go ahead.
Runner's knee is also known as patellofemoral tracking disorder. It's caused by one of the 4 quadricep muscles, your vastus medialis oblique, your vastus intermedius, your vastus lateralis, and then your rectus femoris, which is a dual action muscle, which is a hip flexor and a knee extensor. One of those muscles is not as strong as the other 3, or maybe 2 muscles aren't as strong, and the kneecap is getting pulled in different directions. It happens a lot of times in adolescents, a lot of times females, just due to the fact that the quads aren't as strong as you're developing. They are still weak. So when we go ahead and we check it, some of the things that we will ask our athletes or patients is, where do we have all of our pain? And a lot of times the athlete will just point and say, all the way around my patella or my kneecap hurts. So as we look at that, one of the things that we have them do is go ahead and fire up and make a muscle. And we check to see, are we getting some definition? We always want to look for our tone. So we look to see, relax. We want to make sure that our quads do have some definitions or definition to it. If we don't have the definition, then we know that that is a good problem. Another thing that we do is we like to go ahead and move the patella around side to side or medial, laterally, and superior and inferior. Another test that we can do, since the patella is a floating bone, is we can take our hands and place it at the top or the superior angle of our patella and have the athlete make a muscle and fire it up. We usually ask, does that hurt? And if you apply enough pressure, when you do that, it should cause that bone to go down until it goes down, sits on top of our femoral condyles, medial condyle, and our lateral condyle. So it sits in that area. With it being a floater, we have our quadricep tendon, our patella tendon, and that's what allows it to float. So when our 4 quadriceps tie in and tie into our quadricep tendon and all attach onto the patella, if we don't have the same strength with the muscles, then we can have a problem. Either the pain will be medially or it could be laterally. As we continue on with our examination, I always like to have the athletes check their strength. So one of the things I'll have her do is slide up to the end of my table. And as with every injury, slide a little bit more, right there. As with every injury, we always compare the bad or injured leg to the good leg. So I would check her strength. I can check her strength on her good leg by kicking out first. Kick out, pull back. Now that's hamstrings. When she kicks out, it's the quads. So again, now I check the bad leg, pull back on the hamstrings. So I check the strength right there to see how her strength is, if there was any problems. Because as she sits at the end of my table, her quads now elongated. They went from being in a relaxed state to now they're stretched out a little bit farther. They're still not firing up, but they're just stretched. So another one that I can do is check her hip flexibility. So I have her lay back all the way on the table, make sure the heels are on the table, and I can just go ahead and pull her back this way to see if that causes any pain. I can also open her up to the side to see if there's any pain. But just basically come back this way and come back. Obviously check it with the good leg. So I go good, and now come back to the injured leg. I can open her up this way, I can pull her in this way. By doing that, that gets all of our muscles to fire and see if there's any pain with our patella. Another test that I like to check is checking the tightness of our heel cords. With everything being tied in together, with it going from our hamstrings down to our gastroc into our Achilles tendon, we like to make sure that we don't have any problems when we have her go back into plantar and dorsiflexion. So I bring her up into dorsiflexion, have her point down into plantar flexion, just to see if any of that causes pain. And then one other final test is I have the athlete stand up. And when she stands up, I would have her go ahead and squat down, feet shoulder width apart, and just squat down and bring it back up. And any pain on that, if there is, that's a sign for patellofemoral stress syndrome for runner's knee. Then another one is she can just try to do just a simple jump and landing right, and if there's any pain on that, that can cause, that can be a sign for runners. First thing that you're going to do for the athlete with this injury is ask about their training patterns or training conditions, such as did they increase the amount of mileage that they had on the body? Did they go with a gradual increase, or did they go with a large increase? Also, with runner's knee, is it from the type of surface that you're on, such as a asphalt surface, such as the streets, or running on grass, cross country, or running on a rubberized surface, such as track and field, or the old school tartan surface, which was a rubber surface that is inside some indoor training facilities. Not too many of those around anymore, but it's still a question to ask. Also, did you have a changing a pattern of running hills? Normally when we run, we like to run on flat surfaces such as the streets because it's easier. But if you increase with hills, remember if you go up, you must also come down. So a lot of times people, they struggle going up and then they come down too fast and they run over they start leaning forward too far and it causes a strain to the knee. So you want to ask what their history is. Have they had this injury before? If so, how long ago? Were they in with a physician? Did they just tough it out and it went away after they took a break? So you want to try to get as much information as they can, as you can on the athlete. Your evaluation is complete, and you make your decision to either refer to a physician or to do self-treatment in the training room. One of the things that if you do send to a doctor, they may want to have an x-ray. A lot of times all physicians will take an x-ray because with the patella being a sesamoid bone or a floating bone, you want to make sure that you don't have a little chip in there. You can have imperfections to the patella, and with the grinding, it could cause pain on the condyles and the articular surface of the femur. So if we have all those going on and if something is not smooth in there, that can cause a lot of pain to the athlete. And when that patella starts grinding, we can start wearing away of other surfaces. Initial treatment for the runner's knee is immediately once you determine what the injury is, you want to go with ice. 15-20 minutes on, 40 to 45 minutes off, along with rest. The rest is going to be the main thing. I always recommend for my athletes, you can go with ibuprofen for pain, depending on their size, 2 to 3 ibuprofen tablets per athlete, and then just make sure the rest is going to be the main thing. You got to let it calm down first.